Welcome. Welcome all. I'd like to send out a very warm welcome, not only to our folks here in the studio audience, as I like to say, but also our guests online, especially our Global Health alumni who've signed on to hear our colleague Tina Flores speak. I am Dawn Carey. I serve as Senior Associate Director of Global Health and Development here at the John Sloan Dickey Center. I invite Nicole Wynn, our 2025 MPH candidate, to the podium to tell you a little bit more about the activities of the week. Nicole?
Thank you, Dawn, and thank you everyone for joining. I think we have an awesome week coming up for us. 2 Cartoonivist events tomorrow and Wednesday. A book club on Thursday, as well as a public health career panel Thursday night. Friday, a student-initiated trip to the Vermont State Capitol to speak with some legislators. And then Saturday, a 5K walk run to benefit the Upper Valley Haven. And thank you so much for Tina Flores for tonight's keynote speaker event. Thank you everyone for joining as well.
Thank you so much again, Nicole, for all your work. So I am delighted to be able to introduce our National Public Health keynote talk this evening, No Global Health Without Health Workers, the Role of Advocacy. Before I do so, I have a couple of notes on process before I introduce today's conversation. We'll open for questions from both the live audience and the online audience after the keynote. I suggest that online viewers enter their questions as they think of them during the talk, and you can do so. There's a little Q&A icon at the bottom of your screen to do that. Just a reminder to everyone that Dartmouth and the Dickey Center are committed to protecting free expression and peaceful dissent. With that, we ask you do not interfere or disrupt with today's program. Many of you already reviewed the broad elements of the CV of our keynote speaker, Tina Flores, a 2000 TDI CECS Geisel graduate. As executive director of the Frontline Health Worker Coalition, Tina spearheads the work of their broad and impactful work, leading her team and others to better support boots on the ground workforce for health globally. She's worked in almost every element of global health and public health: noncommunicable diseases, global health security, universal health coverage, and social determinants of health. She established and led the Secretariat for the Private Sector Roundtable for Global Health Security, which is a cross-industry coalition mobilizing the private sector to collaborate with multinational organizations and governments around some of the disease preparedness plans and responses. She's also worked as a private consultant, building off her long stint as Vice President of External Engagement at Rabin Martin. More importantly, Tina began her career as an intern at the Global Health Council way back when it was over in Vermont, working her way to Director of Strategic Communications. This is what internships can do for you, people. That's where she and I met many years ago. In addition to receiving her MS from Dartmouth, she also received her BA from Carleton College. Tina Flores, welcome back to Dartmouth.
Thank you, Dawn and Nicole, and thank you, Dawn, for this very kind invitation. It's great to be back at Dartmouth. I haven't been here in quite some time. And more than 20 years ago, I am where some of you might be, a graduate student at CECS, a bit unsure of what lies ahead and what is next for me. Although I didn't know exactly what a person working in global health did, I did know in my gut that that's what I wanted to do. And so one of my Dartmouth professors actually hooked me up with an internship. And then, the rest, as they say, is history. So internships work, I think. Fast forward a couple of decades, and here we are today. As Dawn said, I lead the Frontline Health Workers Coalition, a pioneering global alliance bringing together a network to drive meaningful change and empower health workers around the world. We advocate for increased investments and pragmatic policies across all cadres of the health workforce, especially those in the low and middle income countries. And we strive to optimize the impact of those investments through pragmatic solutions and implementation. Like the Dickey Center, the coalition convenes people with different perspectives in areas of expertise to improve health. In our case, we do so to accelerate progress on building a stronger, more resilient health workforce so that communities around the world have access to high-quality health services. Global health has always been a challenging field and one that has constantly evolved over time. And the last 6 years have been particularly challenging with the COVID pandemic, among other things. But the reality is we live in a time of multiple concurrent crises. Not just health crises, but extreme weather, conflict, displacement, to name a few. But as you know, every flood, war, political upheaval, and monetary catastrophe has very real consequences on health. Children go without proper immunizations. Whole communities face malnutrition, disease outbreaks occur, and patients don't have access to the care they need for HIV, diabetes, heart disease, cancer, and a multitude of other diseases. Diseases thought once under control, like measles, are now once again public health threats. Health systems are being stretched to the brink. And without time to recover, as you are well aware, health workers are the backbone of the health system. So what does this mean? Health workers across all cadres, that means doctors, nurses, epidemiologists, pharmacists, community health workers, laboratory technicians, and their colleagues are at the front lines of care. And I would say not all of them are even at the front lines of care, but they still make sure that the health system works. From prevention to treatment to care and management of disease, health workers navigate the spectrum of health needs, or patient needs rather, such as maternal and child health, infectious diseases, HIV/AIDS, and chronic disease, or as those of us in the global health community call them, noncommunicable diseases, or NCDs. At the same time, they are addressing emerging health threats, new and old, health-related consequences of climate change or extreme weather, and conflict, which rages around the world and at the most unexpected times sometimes. What we sometimes forget is that when there is a major crisis, for example, the recent earthquake in Myanmar, health workers not only care for the injured, but they also need to care for the women who are about to deliver their babies without a health facility or a trained birth attendant, a diabetic who no longer has access to their insulin, people who need mental health services or life-saving medications. Furthermore, health workers need to do all this while helping to rebuild the systems so that they can continue to provide care to the people in need in the middle of this crisis. So health workers around the world are indeed stretched to the limit, whether they're in New York City Hospital or a remote village in Uganda. Health workers are being tested like never before. We talk about resilient health systems, building resilient health systems that are able to bounce back from stressors. But if we don't put the resources needed now, at what point are these systems and these health workers that support these systems, at what point will they break? The WHO, as you all know, predicts a shortage of 11 million health workers by 2030. This is an increase of 1 million health workers since last year's estimate. We need to ensure that health workers are trained, employed, retained, and that their physical and mental health is protected. Health workers are 4 times more likely to experience incidences of violence compared to other professionals. A recent study found that 48% of nurses from 35 countries reported that they experienced violence and aggression during the COVID-19 pandemic due to their status as a nurse. This is unacceptable. Nobody should be subject to violence in the workplace. Furthermore, health workers need greater access to mental health services and kept safe from the stigma of seeking help. Burnout, poor working conditions, and an inadequate compensation not only lead to poor rates of workforce retention, but also contribute to increased rates of migration. Health workers need to be gainfully employed and earn a living wage so that they can take care of their own families and communities wherever they choose to work. Greater emphasis must be placed on empowering women health workers. Women comprise approximately 70% of the health workforce. Yet few hold senior leadership roles. I will say that this is also true in many NGOs, where 69% of global health organizations are headed by men and 80% of board chairs are men. I will say our parent organization, Global Communities, is headed by a very capable woman. So is IntraHealth International, who is our host organization. Women health workers in particular need greater opportunities for additional management and leadership training so that they are ready to step up into senior positions when they become available. And furthermore, they should have the resources and other tools they need to succeed when they do so. Greater commitments from all sectors are needed to realize a resilient health workforce. Funding is critical. You can't get around that, whether it's from large or smaller funders. Everyone needs to make health workers a priority across the different disease areas. Countries also need to make greater investment in domestic spending for health, and specifically for health workers and employing health workers, not just training them, but also employing them. But equally important are the technical assistance, pragmatic, actionable policies, networks to access the resources, and the experience to leverage them and use them wisely. Investment in health workers not only improve health outcomes, but also contribute to stronger economies, not just in health in LMICs, but also in wealthier countries. So where does advocacy fit into all this? I mean, who cares? Some people say. Advocacy drives change, and partnerships enable greater, more effective and sustainable programs. So what is advocacy? What do you all think is advocacy? Don't be shy. Okay, we're gonna be shy. Fair. To me, advocacy has three core components: evidence, engage, and activate. Evidence. Use data as the foundation. The more concrete the data, the better. And data is always stronger than anecdotes. Engagement. Why should your audience or stakeholder, it could be a government official, it could be students, it could be the NGO of an organization, why should they care about the particular piece of evidence or data that you're presenting them? What makes it relevant to them? And what are they going to get out of it? A critical part of engagement is listening and understanding to what drives your stakeholder. And use stories and images to bring that data to life and make it relevant to them. And you also need to make sure to do some research on who your audience is to better understand what makes them tick, what drives them, and what is going to make them be more receptive to the data or evidence you're presenting them. And finally, activate. What are you asking them to do? This is also known as the ask. What's the ask? Do you want them to change a policy? Do you want them to vote a certain way? Do you want them to make a specific investment or do a specific type of research? Use what you've learned in the engagement portion to make sure that they can deliver on the ask. So today marks the official beginning of National Public Health Week, as Nicole mentioned. And it's also the official end of World Health Worker Week, which the coalition has led for the last 13 years. It's also World Health Day, which is led by the WHO. So why are these days of observance so important? A lot of energy, as Nicole can attest to, goes into these observances, but do they work and what exactly do they do? So these days or weeks of observances really provide opportunities for people with aligned interests to come together to recognize achievement, progress, and advocate for change. This World Health Worker Week, for example, we wanted to highlight the importance of the health workforce and that the health workforce is the heart of health. And you really can't do anything in health without the health workforce or health workers. It just boggles the mind that people think you can. But at the same time, it's also an opportunity for us to call for increased investments, protections, and respect for the health workers who have dedicated their lives to the well-beings of their communities. Strengthen, invest, value, protect. Now you think, how much of a difference can this actually make? And I will say last year, I did try to kill this. It was my first year on the job. It was like month 2 when I was like, I don't know. Seems like a lot of work. What do we really get out of it? So 95 million audience members later, the reach of last year's World Health Worker Week was 95 million around the world. I was like, okay, wrong. Obviously, we'll do it again next year. Bigger, better, whatever. So this year, thanks to the wonderful Abby Savin, Class of 24, who started as an intern over the summer and then later applied for and hired for this position, which is not super entry level, and beating 105 people. Literally 105 people, including a White House intern, but that's okay. This year, leading global health institutions such as Gavi, the Vaccine Alliance, the Global Fund, UNICEF, and some of the world's leading organizations, including CARE, Project Hope, Smile Train, companies like Johnson & Johnson, and FIGS, the Scrubs company, their partners in World Health Worker Week as well, have already participated. Tomorrow, Newsweek will publish an op-ed by Vanessa Carey, President and CEO of C Global Health, Robbie Torbay, President and CEO of Project Hope, and me on the importance of human resources for health and why it's an important time to make sure that we do invest in them. I invite you to take a few moments to post something on social media about World Health Worker Week or, National Public Health Week. We handily have the QR codes and the hashtags here to support health workers and to support public health across the U.S. In addition to large campaigns, advocacy necessitates a more targeted approach. So you see the large campaigns. What you might not see are the closed-door sessions, the roundtable discussions, the phone calls, the one-on-one meetings with donors, governments, legislators like members of Congress, multilateral institutions, and advocates from across many sectors. Advocacy can be a very powerful tool, especially when you are most discouraged and when you feel like nothing is in your control. You need to start with one person and then another and then another. And soon you will find those with whom you share a common goal and common targets. You might not agree on everything, but you can agree on one thing. You don't have to be loud or charismatic. You don't have to do anything big or bold with a lot of fanfare and hashtags. And you won't convince people all the time. In fact, advocacy is about small gains. So a crucial word or two added in a political declaration or one of those global negotiations like the pandemic accord. Last year, we got 2 words into the pandemic accord, the final language, and we were like, oh, yay, that's great. A phrase in a policy document or a speech delivered at the World Health Assembly. Gain a supporter one day, cultivate a champion the next, listen to a counter argument the day after that. Sometimes these calls are like consecutive in the same day. It's not about winning, it's about moving the needle in the right direction. The last several weeks have been the most challenging and heartbreaking in global health and domestic health. But the needs of health workers and the need for health workers, researchers, public health people in the US and around the world will continue. Without health workers, there is no health equity. In fact, without health workers, health and development goals become unattainable. I challenge you this week to do some small form of advocacy, particularly when you're feeling the most discouraged. It can be a conversation with a friend, a social media post, an email to a policymaker, maybe one of your state or local legislators. Start with the evidence, make it relevant, and make the ask. When there is advocacy, there is hope, because people care enough to do something. Thank you. Questions? It's okay if you don't have questions. Dawn says it is not okay. Great.
I'm also going to help get these out. I wrote it down,
Great,
sorry.
thank you.
Okay, my name is Evan, and
Hi, Evan.
we previously had a talk last week by someone from a representative of NATO. We were talking a lot about NATO, and something that they brought up was that the U.S. is going, or is in Europe right now, advocating for an increase in the budgets of these European nations for specifically defense. And one thing they noted was that maybe that would reduce budgets for health or other things like that. And I was curious what you would say would be the best way to advocate for health budgets, not only in LMICs, as you mentioned, but also in Europe and other countries that previously have had very strong health systems. And how do we talk to those people that think of health as secondary to things like defense?
That is an excellent question. Very excellent question, actually. So, as you all know, basically every country has a pot of money. And health, in the realm of things that governments have to spend on, health is not a priority. We all know this. In many cases, health is not a priority, not to make generalizations. So what we need to do is convince the people who hold the purse strings, i.e. ministers of finance, trade, heads of state, that health needs to be a priority. And usually the strongest arguments are economic ones. So what is the economic return on investment, but also what is the loss, the potential loss? So when I was doing work on global health security, it was between Ebola and COVID. People who were not based in LMICs and who didn't have large investments in LMICs were just like, this is not going to happen. And I was like, no, it's going to happen. It's going to happen. Well, it happened. And so people then understood and saw the economic argument. But unfortunately, because COVID had such a great impact on human life and the economy, there is a lot of that data there. There's also there's a particular paper that the CDC authored several years ago now where they essentially used trade data, American trade data, to make the argument for why it was important to protect the health security of other countries. So I think those types of models and those types of examples, the economic rationale, from a trade perspective, from an employment perspective, sick people cannot work, whether it's because of an epidemic or because they have a chronic illness, like cardiovascular disease, diabetes, HIV/AIDS, etc. So, yes, we can talk about this for a very long time, and I'm certainly happy to, but yeah, look at the economic argument and talk to the people who hold the purse strings. Hi, yes.
Hi, Tina. Thank you for joining us tonight. I have a question from our online audience. How can we use evidence-based advocacy when the people we're trying to connect with don't recognize our evidence as valid? So, for example, anti-vaccine groups being presented with studies about the safety of the measles vaccine. If they don't acknowledge facts that counter their own beliefs regardless of the source, can and should we fight for that evidence pillar in advocacy? Or are there situations in which advocacy might make more headway with evidence set aside initially?
That's a good question. I am of the school that evidence is evidence. So, and I do believe that the best advocacy needs to be rooted in some evidence. Now, one thing to consider is who are the drivers when you talk about engagement? Like, what can you manipulate? What can you adjust in the engagement portion of that situation? So what drives the people who don't agree with your evidence? Why don't they agree with your evidence? And sometimes you have to advocate to the people who influence those people. And sometimes you have to move on and just agree to disagree or try again another day. I say try again another day. Agree to disagree and try again another day. But definitely think about what is driving that. And I think that the vaccine movement is a very challenging case. But in some cases, when somebody says, well, I don't know about that, you can say, okay, but we talked to this person and they think X, Y, and Z, and they said, oh, really? And then they talked to this person and this person might be able to convince them because they respect this person.
Thank you so much for being here, and thank you for the talk. I'm reflecting a lot on the recent changes in U.S. funding priorities and how this plays into the public and global health landscape. And I have two questions. The first part of this question is, how are changes in U.S. funding priorities specifically going to impact health workers? What can we do to best support them? And then in a longer timeline, I guess I'm wondering, as we maybe start to build back from all of the changes that are happening now, if there's a way we can do that creates a public health infrastructure that's more supportive of health workers.
Thanks. Great question. As you know, health workers around the world have had to be laid off in many cases until there is funding to once again provide them with jobs, and hopefully solutions will come sooner rather than later, and wherever the funding comes from. Second, so to be supportive to health workers now, reach out to leaders and say, like, this is important. This is an important investment. Again, go to the data, tell them why it's important, and make the ask. And the ask is, make these investments in global health, in domestic health, in health workers. And I think in terms of strengthening the health workforce, the health system, to be more health worker friendly. Okay, just checking. I think there needs to be emphasis on women leadership and making sure, because women comprise so much of the health workforce, we really need to make greater investment in women leadership and women leaders, and all leaders, and to help them educate, okay, like, you need to protect the workforce. You need to make sure that their physical health, not just PPEs, but chronic diseases and other illnesses caused by the types of jobs that they do, but also their mental health is cared for. And we need to rethink about human resources for health and human resources for health funding so that they're better integrated into the health system and they're not disease specific. So sometimes there's specific programs that will only support particular salaries for a particular disease area, and maybe rethink about, okay, how can we extend that? How can we, and I had another point about health workers. I forgot. I'll come back to it. Thank you.
You talked a little bit about how you were invited into spaces to help strengthen the healthcare workforce, largely speaking. Before the chaos that was going on now, I'm sure the United States certainly funded a lot of these elements because there's so much of what we provide around the world that would be dependent on having this, strong health workers coalition working out there. In absence of U.S. funding, who's going to care about this now? Who in the private sector or in the philanthropic area is going to care about this? Who's it going to be important to going forward, assuming that the U.S. is not as strong or is a parallel partner?
That's a good question. Oh, and reminds me of what else I was going to say, the previous question. So there needs to be greater mobilization of domestic health spending, resources for domestic health spending in LMICs. You know, what we talked about, allocating more funds and making those investments in the health workforce. I think the private sector is an important partner as well. They're huge investors in LMICs. They are major employers in countries around the world. Yeah, I mean, and obviously philanthropy and multilateral donors.
Hi, I'm Camila. It's nice to meet you.
Hi.
I had a question about so for domestic health spending, how do we, as people in the US, advocate for more domestic health spending? How can we support those efforts and create more capacity domestically in countries so that, if we take away funding, countries can support their health efforts and invest in their economies?
So that's a great question. Also, a lot of good questions today. I would say providing local advocates in those countries with the tools they need to make those economic arguments to their legislators, the people who hold the purses. So arming them with messages, facts, helping them with different models. Maybe they can be economic models that will help them make that argument is a powerful tool. And also working with them to better understand what the options are for innovative financing or alternative sources of funding, mobilizing their own regional and local private sector or industry, as some people call it, to provide some of those resources. There are no cut and dry solutions, but these are some ideas. And so to that end, actually, the coalition, the Frontline Health Workers Coalition, was a partner with the WHO, the Global Fund, and the WHO, the Partnership for something, I'm going to mess it up. Anyway, last May, we co-hosted with the WHO and these partners the Africa Health Workforce Investment Forum in Namibia. And it was a forum that really brought together high-level stakeholders from the continent to explore and better understand why investments in human resources for health are critical, and to launch this Africa Health Workforce Investment Charter, which is available online for those of you who are interested. And we have seen results, and there have been countries that came out of that and where they did increase their health budgets for health workforce specifically. So there were ministers of finance and trade, et cetera, were invited, and a few came, and there were a few that when they went back to their country, they said, okay, we need to invest this money to train health workers. And they have. And, progress has been made in terms of helping other countries realize some of the benefits of making greater investments in health workforce. Any other? Internships are important. Is that going to be your question?
No, but I do agree that internships are really important. One of the things that I've found is that the Dartmouth Institute, of which you're an alum, has so much great research on healthcare co-production and shared decision making. And I was fortunate enough to go
Shared decision making.
the
Yes.
ISQA conference last year in Istanbul for quality in healthcare. And they literally spent 5 minutes talking about Dartmouth's leadership in healthcare co-production. And one of the things I wonder is how we can translate that research outward in a way that's helpful. And Professor Glenn Elwin, who's on the faculty here, and some of his colleagues have done some work, and they have an instrument for shared decision making called Collaborate. And one of the things that they've found that's universal is the question, like, what matters to you, and why? And I wonder how much progress we could make across countries if we started conversations often with what matters to you instead of starting with, this is what I think we need to do.
Yeah, that's a great point, because what matters to you speaks directly to that engagement portion of advocacy. So you're basically asking your audience, why would you care about? What are the things you care about? And then you can tailor your argument around that.
Well, and I found another piece that you brought up. One of the things that I found fascinating about your keynote is how you started with evidence, because almost always when you read a lead in a newspaper, it starts with a story before it starts with the evidence. And I think that that's an interesting way to think about what we're working with in sort of the age of misinformation as well.
Yeah. So I used to do a lot of communications. I used to run a magazine for Global Health Council back in the day. And, we used to, when people read long form before social media, there was always a story, then you do the argument, everything was neat and tidy. Now, what I tell people is, if you want to make a point, put it in the first paragraph, because you cannot, or even the first 2 sentences, because you can't count on people to read the whole story. So if there's a story, if there's an article with a great story on top, I will read the story, but I might not read beyond that, because we now live in a completely different communications environment. So I think when I say start with the evidence, I mean, like, start your advocacy campaign and your messaging with that. The evidence needs to inform what you do and what you advocate for. So, yeah. I'm trying to, yeah. Because otherwise it's kind of fluff. It like, there's no substance. People might disagree, but I think you always make a stronger argument if you have actual facts. And people might not disagree, might not agree, but I don't know. It's usually more challenging to disagree with actual facts, usually.
I like the usually. On that note, I'd like to have everybody join me in thanking Tina Flores for this amazing keynote and kick off to our week.